today we are going to talk about supporting the postpartum mother, so after birth. We do have a video that was done by our lovely midwife Lisa Marie, but she was at a birth all weekend, literally all weekend, so has only just sent it across to me, so I will upload that tomorrow for everybody. But yeah, that's when babies just get in the way sometimes, and she couldn't do it as planned. She was at a very long birth. But we're going to be working today on things like postnatal depression, body changes, who's who, so who you might find in terms of healthcare professionals around the home postpartum, and then a little bit about healthy eating. So the first thing we're going to do is to think about 3 different types of changes that happen to people after they've had a baby. So I'm going to ask you to name some, and we'll put them on the slide. So they're in 3 different groups: mental health, physical health, and relationships and lifestyle. So anyone got a change that they think happens after people have had a baby?
I'd say relationships, they have a dependent.
Mm-hmm. Good. Yeah, and that adjustment from couple to parenting, especially the first time round, is absolutely huge.
Mental health, mother has all the hormones up and down, so
yeah, absolutely. Let me pop that up there, and we can put that there. Hormones affecting emotions.
It's not the R in.
Thank you. There we go.
And gaining weight and physical.
Gaining weight. Did you say, Bella, gaining weight?
Yeah.
We're talking postpartum, so we would expect women to have gained the weight during their pregnancy and not to gain any more weight afterwards. So postpartum means after the birth.
Yeah.
Mine, yes, before.
Yes, if it's afterwards, then you're eating too much cake. You know, on hope, if you birthed a sort of a 6-pound baby, some of it should go down. You know, the weight doesn't go down as much as you'd expect, but definitely we should see a little bit of a reduction there.
So, can I say something?
Yeah. Please.
Okay. So the body changes as well, like the pelvic floor changes. So
for the worse or for the better?
For the worse.
And one of the
everything
videos,
becomes loose a bit.
One of the videos I uploaded for this session that you might have watched or you might be watching afterwards is around our postnatal fitness trainer, who talks a lot about the pelvic floor and how that changes. So very important.
Yeah,
someone has just joined us, but we haven't got the name at all. It just says Manta Admin, so I don't know who that is.
It's Claudia.
Hi, Claudia. Have you got my text? I said, have a read of my text, because if you're in hospital, you really shouldn't be attending, my love. So please, we all wish you a very big get better soon, don't we?
Yeah.
But you spend your time resting and have a read of the text I sent you.
Oh, I just got it now.
But we do hope you feel better very soon. But yeah, if you're in hospital, then you're definitely too unwell to attend today.
Oh, okay. Thank you.
But we all send you our love. Get better soon. Oh, there's dedication. Right.
I would say, obviously, as well, if the mum has had a C-section, a cesarean, she's going to have healing with her scar.
Yep. Absolutely. Cesarean healing. Let me pop that in. Oh, wow.
What's that?
They all represent something. C is for...
yeah, it's an acronym. Okay. Any other changes to the body, the hormones?
How about sagging?
Sagging, yeah. Yeah. Skin tone. I'll put it in the next way.
Yeah.
Yes, it all goes a bit south, doesn't it?
And after baby, mum can become very stressed because of change of sleep patterns.
Yeah. So we put that in mental health?
Postnatal.
Yes, yeah.
postnatal depression.
Stress from lack of sleep. Oh, goodness me. New keyboard today. And did you say postnatal depression as well, Leanne? There?
Yeah.
Which we cut as PND, postnatal depression. Other changes, think about lifestyle perhaps, or the relationships?
Yeah, so maybe a second child, that's the first child, should I say.
Yeah, so we can have sibling issues.
And even the partner relationship as well will change.
Absolutely.
Yeah.
Huge adjustments there.
Sharing a bed and
But sex life as well, because it's, you know, sharing a bed, but it's the intimacy as well, isn't it?
Yeah.
Things are different. Not necessarily bad different, but they are different. Thinking more about the physical health, bleeding. Anyone know the name for bleeding? Lochia, which is the postpartum bleeding. Okay, any other? We've got a few more on the other slides, but any others that people want to mention at the moment? Okay, we can always come back and add some more in. So we weren't going to have the video here from Lisa Marie. It's all prepared, ready, apart from today. She hasn't sent it to being at the birth. So I will send that on as a webinar upload after the session. But it adds to what we've got. It's not anything, we're still covering everything. It's just hearing it from a midwife's perspective, which is really useful. But the important point is that we don't talk about all of the changes. And when we go to the next few slides, there'll be some that if you haven't had a baby, you may go, oh, really? Because as women, as people, we don't talk about all of the physical and mental changes that happen after birth. And they can be really surprising. So if we know as professionals what is normal, we can reassure parents about what's happening, but also we know what's then not normal, and we can signpost them to healthcare professionals if what's happened to them isn't what to be expected. So do watch out for the video from Lisa Marie, which I'll be adding tomorrow. But the changes she talks about include, so stretch marks, and I've put them as problems and things that we can do to support parents. So stretch marks, fundamentally, they're going to be there. There's, you can rub in creams and so forth, but there's not a lot that you can actually do to get rid of them. So a lot of it is about celebrating and helping the mum to celebrate and her new body. Hi Fiona, I'm just going to mark you in. How are you doing?
Hi, Caroline. I'm good, thank you.
Good stuff. We're just talking about postpartum bodies, what your body's like after birth.
Okay.
So what was I saying? Yes, so stretch marks, they will generally fade over time, but actually celebrating that it's okay not to look the same, because you've just birthed a tiny human, or more than one if you've had twins. So it's okay for things not to look the same afterwards, because it's a celebration of what your body has done. Breast engorgement. So we talked about this in the breastfeeding module. At what day would you expect breast engorgement to really start to hit?
Around 4 days.
Day 3 to 5.
Yeah. Right in the middle.
Absolutely. So roughly day 3 to 5, we might expect to see that enlargement. It often happens overnight. Often can feel like really big concrete boobs. I've got a great photo of me with the baby's head here. And I swear my boobs are bigger than the baby's head. Really quite, whoa, that's a cleavage territory. So again, reassurance it's normal, and we make sure that mum is frequently feeding or expressing cabbage leaves, cold between feed. Breast engorgement, however, will hit women if they're choosing to formula feed. So who can think of ways that we could support a mother who said from the outset, I do not wish to breastfeed, I wish to formula feed? Because as we know from our breastfeeding support module, these bodily changes will happen however you've chosen to feed your baby. It's only after this period that the breast milk starts to be produced in relation to what the baby takes out. Up until that happens, this breast milk will come in even if she's never ever wanted to breastfeed and she only ever wants to formula feed. So obviously for someone who's formula feeding by choice and is not wishing to up her supply, we wouldn't suggest frequent feeding or expressing. What would we suggest to those mums? Anyone got any old wives' tales that they can say we definitely wouldn't suggest, but they've heard happen? Because this is a fair few mums that will choose formula feed, but this will still happen to their bodies. What we won't do is we won't suggest that they bind their breasts. That used to be suggested, but it's really not very good for parents. It's made them more likely to get mastitis. We're not going to suggest that they're going to be expressing a lot, but they may wish to hand express a little bit of milk just to relieve that engorged feeling. So we're not aiming for stimulation, but we are aiming for them to be relieved. Going to suggest pain relief for them. So paracetamol and or ibuprofen. A good supportive bra, so something that's like a little like a sports bra that's going to keep everything in place, but is not going to, bind the breast down. And cough medicines can actually suppress breastfeeding. So when mum is breastfeeding, there are actually some medicines that we say would, probably steer away from, because we, don't want to impact on her supply. So things like Sudafed can impact negatively on breast milk supply, but that can be used to the benefit of women who don't want to breastfeed at all. Some doctors will actually suggest other medication to dry up the milk. So it might be that, if she knows she's not going to want to breastfeed, then talking to her midwife about a visit to the GP before the baby's even born might be something to look into. But what do we know about breastfeeding? If the milk doesn't come out, the milk isn't being taken out by pumping or the baby because the mum wants to formula feed, what will eventually happen to that milk?
It would dry up.
Yeah, she won't be making more, because that feedback inhibitor of lactation, which is keeping her, is in her full breasts, will be stopping more milk from being made.
So obviously, from 6 weeks, your supply is supply and demand. So would that mean?
Not from 6 weeks. From 6 weeks is when the supply is fundamentally the same.
Yeah.
Supply and demand is kicking in at this time. When lactogenesis 2 is happening and it's changing from the colostrum to the mature milk, that is when it's changing from an endocrine process, the hormonal process of you will make milk whether you're wanting to or not, to the autocrine process. So at that point, when the mature milk is coming in, if it's not being taken out, the body goes, oh, okay, stops producing.
And when say obviously they do breastfeed and then they decide to stop after the 6 weeks, will it kind of be a slower process because you have been you've trained obviously how much milk to in that stage of supply and demand? Will it be longer after 6 weeks to dry up, for example?
There's a different process in so much as if you're never ever wanting to breastfeed, you want this to happen as quickly as possible because there's no impact on baby. Baby was never getting any breast milk, and you don't want to start building any supply. So when the supply is automatically building in those first few days, you want to be saying, like, just no more, folks, stop now. So there's that initial engorgement, but then because nothing's coming out, nothing more will be made. When you've established a milk supply, to just go stop feeding, that's it, you are very likely, because obviously the milk supply has gone up, to then hit engorgement, blocked up from mastitis. Well, mummy. So women who have never chosen to breastfeed and then at day 3 to 5 are getting engorged breasts are still at risk of blocked ducts and mastitis, absolutely. But those women who have a supply that's established because they've been feeding their baby every 2 hours for the past 6 weeks, you know, the impact of just stopping full stop on them is obviously going to be huge.
Yeah.
So a step down approach of dropping a feed every few days is what's recommended if that is their choice. And that will be the same for whatever stage of breastfeeding they choose to stop at.
Yeah.
So that would be A, getting baby ready for something else, but B, giving the breast time to step down that approach.
Yeah, yeah.
And obviously there are some women who can't do that. You know, if someone it's fairly rare, but you get a cancer diagnosis or something and your doctor says you have to have chemo, this will mean you need to stop breastfeeding. There are some women for whom they just need to stop right now because their health is at risk.
Yeah, yeah.
And so there are some medications that can support with that when there's a particular medical need. But when it's been a choice or a I'm done with this now, then stepping down one feed every few days is much better for the mum's well-being.
Yeah. Okay.
Something to be aware of, that stopping breastfeeding has a hormonal impact. So if you're never breastfeeding, day 3 to 5 anyway is, as we'll learn, baby blues peak time. So the hormones are going to be all over the place. Be aware that if a mother's breastfed for any length of time longer than that, when she stops breastfeeding, her hormones change and she's likely to have a drop, a bit like coming off drugs, and you know, you're high and then there's a drop afterwards, because the hormones are the drugs in the system. So she's going to have less serotonin being produced, less oxytocin in her system, and the drop down off that can be, you know, really quite noticeable in some women. Some women sail through that, others they have a real hormonal drop at that point. So if you're supporting someone who's choosing to stop breastfeeding or to take their breastfeeding down for whatever reason, make them aware and be aware that their hormones will be affected by this to a lesser or greater extent.
Okay.
After pains. So who can explain to me what after pains are? What do I mean by after pains? Sally-Ann?
Oh yeah, I've gone through them. It's like when you feel like you're contracting still after a baby's been born, and it goes for days.
Absolutely. Do we talk about this a lot?
No.
So many women think something is very wrong. And I like to explain it like there is a direct link between the nipple and the uterus. This is one of the reasons why midwives encourage frequent feeding very soon after birth. A, it's super good for the baby, but B, that feeding after the birth is also super good for the mum, because that suckling has that direct link through to the uterus and helps it contract. And directly after the birth, that supports mums not to postpartum hemorrhage. So the quicker the uterus can contract after having a baby, the less risk there is of bleeding out, of postpartum hemorrhage. So that really early breastfeeding is super important for mum's well-being. And that continues over the first few days and even, you know, a week or two of the breastfeeding relationship. Because every time baby's suckling, the uterus is contracting. So be aware with formula feeding mums, they are not going to be having that impact on their uterus. They're more likely to be at risk of postpartum hemorrhage. So one of those other things where nature knows kind of what it was doing, it set the system up where breastfeeding would help contract the uterus. So if that's not happening either through choice or through medical reasons, just something to be aware of, that won't have that impact on the mother's body. So yeah, those after pains feel like contractions because that's literally what they are. It's the uterus contracting down and the sucking of the baby is causing that. And it can be super sharp, can't it, Sally-Ann? It can be really like, seriously, I've had a baby, I've gone through all of this. What are you doing to me, body? But there's a really good reason for it. So reassuring mums, it is painful, that is normal, and the reason is your uterus is contracting and that's helping to stop any risk of bleeding. Any questions on that one?
So people that have like mastectomy, they're at a really big disadvantage.
Yes, absolutely. If for any reason the baby is not feeding at the breast, which could be formula by choice, formula because baby's not feeding well because of tongue tie, or they have a mastectomy, there's no breast tissue there for baby. for whatever reason it is, if baby's not here at the boob, that uterus is not getting the signals. Obviously,
No.
it does go back over time,
Okay.
but the breastfeeding is helping that happen. So those mothers are a little more at risk of the postpartum hemorrhage. Again, it is very rare, but something to be aware of. Caesarean scar pain is pretty straightforward. Someone's cut into your stomach. There's about 7 layers they've cut through. They've sewn up all of the layers together. It's going to hurt. It is major surgery. And what people don't realise is quite how much mums who've had a caesarean have gone through, and are then expected just to also care for a new tiny baby. So it's not an easy option. It's not too posh to push. It is, you know, if it's a choice option or whether it's an emergency option, it is a big operation. And frankly, if we sent our chaps in for major stomach surgery, would they be looking after the babies afterwards? Or would they be laid up with the grapes? I don't know about yours, but it's something we expect women to do an awful lot when they've just had major stomach surgery. So keep ensuring mums keep up with their pain relief, unless they're making a conscious choice not to have pain relief for moral or ethical reasons. Then reminding the mums to take pain relief at the appropriate times, every 4 hours for paracetamol, every 6 hours for ibuprofen, or as directed by their hospital. Don't let them get to the stage, if they're happy to take pain relief, don't get to the stage where they're like, oh, I forgot. If you're the maternity nurse there, part of your job will be to remind mum, or to help her set reminders for herself, take that pain relief on time, because it's more effective when it's kept topped up rather than if it's left to dip off. And there's no, being brave about this. You've just had a major operation. Pain relief is appropriate. If they're breastfeeding, it will not harm their baby. So getting them to keep up with that is really important. If you're not chatting at the moment and you're moving around, if we can just have on mute, that would be really good for the video. That'd be fantastic. Thank you. Potential DVT, deep vein thrombosis, or blood clots. Much more common in the last few years than ever before has been to give women injections to take home. So it used to be pretty rare, but now it seems that every other woman has been given injections to self-inject into her stomach or her thigh for often 10 days. It can be longer after the birth. It can be because she is overweight, she's over 40 or over 35 in some areas, that she's had multiples. There's a whole host of reasons why doctors will have prescribed blood thinning injections. And it's a stab and a push. Mums will be taught how to do that before they leave hospital. Their partner may choose to do it for them. They may choose for their partner to do it for them, sorry. Is it the job of the maternity nurse to do a DVT injection?
No.
What might happen if you agreed to do that and it went pear-shaped?
You would be blamed, or you could be liable.
Mm-hmm. Just like you wouldn't give an adult medicine, you wouldn't put it into their mouth, would you? You're not a nurse. If they're that unwell that they cannot take medicine, they need medical care. If they're unable to do the injection themselves and they do not have a partner who can or is willing to do that, it is not your job. They will need to contact their community midwife. And maybe you support them by going in with them every day to the clinic where a midwife will do that injection. And the midwives are very good at helping mums to get to do them themselves. They do not want to be doing injections every day for 10 days, but it is absolutely not your job to do the DVT injections, and you must not agree to do it, as that is medical. And if something went wrong with you injecting someone, this is not a lawsuit I ever wish to be involved in. Hi, Lethea. All safe home from work.
Yeah.
We're talking about postpartum body changes at the moment.
Yeah, thank you.
So you'll see the ones we've talked about already on the screen. We're just down to anemia. So really fun one, lots of blood loss. So particularly if women have had extensive blood loss or hemorrhage after birth or at the cesarean, they may be more at risk of anemia. Some just get anemia because of the state of going through pregnancy, poorer diet, and all of those changes. So if your mum is seeming very tired, I mean, all mums seem very tired, but very tired, skin pallor or pale, really struggling, it might well be worth getting her checked out by her GP and to have an iron test. And self-help measures would be having iron-rich foods and the doctor prescribing some iron tablets, which, be aware, they can cause constipation, which is all fun when you've had a baby come out of you, whichever way. So can be good, can have negatives, be aware. Right, let's pop to the next page. Okay, well, it's all the fun things on this page, all the down belows. So as maternity nurses, it's not up to you to be squeamish about these things, but you know, let's not talk in euphemisms. Let's be really clear with mums about what's happening to their bodies so that they can understand what's normal and when to seek additional help. So, is incontinence, both wee or poo, coming out of you when you don't want it, normal after childbirth?
Yes.
It is very common, but just because it is common does not mean that women should just go, oh, well, that happens, gonna live with it. So although it is common, it's really important to reassure new parents that there are things that can be done to support them to regain their pelvic floor and to regain their continence. Talking about urinary incontinence first, so that's weeing. Pelvic floor exercises will obviously be really key for this. Making sure women drink. One thing, if you're weeing a lot and you're not, you didn't want to, one thing it's really common and easy to do is go, I'm going to drink less because then I'm going to wee less. But actually that is self-defeating, because the bladder will then get smaller because it's not having to deal with as much urine going through, and it means that actually it's not making the problem get any better. So encouraging women to actually drink 6 to 8 glasses of fluid a day. And although we know that breastfeeding, fundamentally, you don't need to change your diet, if you have urinary incontinence, then you would want to consider whether the mum wants to cut down on her caffeine, spicy and acidic food to help with that. If it's not improving, and especially not improving by the 6-week check, that is something that the doctor should now be getting involved in and referring on to a continence clinic for support. Incontinence can also be poo, though. It can be poo coming out when you don't want to. This is more common when women have perennial tears. There are 4 different types of tear, and the most serious will go through to the anus, so through to the bottom and into that tissue. And women who've suffered from that can well have double incontinence, so they lose both wee and poo. It is very unpleasant for them, it's very worrying. So if anyone has a 3rd or a 4th degree tear, they should be already being referred on for additional support around continence. That should be a given. And if that referral hasn't happened, it will be important to support them to go back to the GP and say, this is something that I require. Because that, although hopefully we'll get better into a little bit in time in terms of stitches healing, it's something that does need to be dealt with by the appropriate professional. So that will come the same as the constipation, that you want to be having a fibre-rich diet, plenty of water. If they're constipated rather than incontinent, if it's not coming out, they may well be getting laxatives from their GP, and that would be appropriate. So lots of things can happen down below that are not pleasant, but if the mums don't feel confident in talking to you about them, then they won't necessarily be being signposted to the right help for them. So you be the one that opens up the conversation. If mum says, I don't want to talk about that, that's fine. But if you've asked the question, have you been going to the loo okay today? Has pooing started to get back to normal? If you show you're completely fine with these conversations, it opens up the option for mum to talk to you about it. So other things that can happen underneath, hemorrhoids, oh, what fun. So that is where the blood vessels in and around the anus have become enlarged. It can be very itchy. They can come outside of the anus like little bunches of grapes. Pretty uncomfortable, pretty horrible, and can often happen in late pregnancy. It can also happen after childbirth. So again, that fibre-rich diet, plenty of water, aiming to reduce any constipation. And there are proprietary creams that you can get from your pharmacist for this. Again, if it seems to be very severe or there's bleeding as well, we'd be going back to the GP. Bleeding, or it's called lochia. This blood loss is like a heavy period, but it's not just a period, it's everything that's been inside the womb. This happens whether you have a cesarean section or a vaginal birth. Some people think that, oh, if I've had a cesarean, they'll have cleaned it all out and it will be fine. That is not the case. With a cesarean birth, you get the same bleeding out for the first few weeks after birth. Can last up to 6 weeks if it's still going at the time of the 6-week check with a GP. That will be something for them to start investigating. But over that 6 weeks, it should become progressively lighter fairly quickly, and it will change from blood loss like a fresh period with some clots in it through to creamy discharge towards the end of that 6 weeks. So mums are encouraged to use sanitary pads that are particularly for this type of bleeding. You know, now is not the time to be with those little thong-shaped jobs. You want something that's really going to soak everything up. Avoiding tampons or moon cups. We don't want to be putting anything up because there'll be an infection risk there. So if mum usually uses that, this time is not the time to do that unless they've talked through their midwife and they've discussed those infection risks. If you have clots, so large clots larger than a 50p piece, mum should be checking in with her midwife to make sure if everything is well. So some clotting coming out in the early days is normal, but if there's very many or they're large, we need to get that checked out from the midwife. And then the last thing on this fun slide is perennial discomfort. So that's the area all underneath your vulva. So it might be from stitches or tears or grazes. It might just be because you've pushed a tiny human out. But it can be very tender and sore. So good tips to suggest to mum is to have a jug of warm water to pour onto herself when she's peeing, so that if you know, like if you've got a cut on the finger and you put your finger in salt water, that's going to sting. If there's any cuts down below or grazes, pouring that warm water on while she pees is a really good way of lessening that. Or if she really doesn't want to do that, encourage her to pee in the shower. And it's just a way of helping to relieve that pain. Making sure she changes her pads frequently to lessen any risk of infection. To do her pelvic floor exercises. It sounds a bit counterproductive. Think, well, you know, everything's hurting down there. I don't want to do any exercise there. But actually, it brings blood flow to the pelvic floor region, and the more blood flow we've got going round is going to encourage healing. So pelvic floor exercises will help with healing. If she's in pain, she can be taking painkillers, paracetamol, ibuprofen. Cold pads, or padsicles as the Americans call them, can be really good for pain relief. So on just a normal, you can buy them, but they're expensive, or a normal sanitary pad, you can put a little alcohol-free witch hazel or lavender or aloe vera gel, and then wrap that in foil, pop it in the freezer. And then when mum wants one, she takes it out of the freezer. Don't use it straight onto the skin. Imagine the freezer burn. So leave it for a few minutes, unwrap it, leave it for a few minutes so it's cold but not frosty. And then she pops it into her knickers. So those can be really good relief. Someone's got the police going past. Some people will talk about sitting on little rubber rings and so forth. It can give some temporary relief, but it can also restrict blood flow. So if mum wants to do that, we're only wanting 20 minutes at a time and then changes of position so that she doesn't actually do more harm than good. If she hasn't had a cesarean, she might want to try a warm essential oil bath, again, to relieve the pain in that area, and then we'll be going for something like lavender or aloe vera within the bath. And we've got Habiba now. Hello, Habiba, how are you doing? I can see her.
I'm good.
How are you doing?
I've been here.
Hi, I didn't see you pop up. I'm so sorry. I didn't welcome you earlier. I'll pop you onto the register. All good. My apologies.
It's all right.
Right. And so the third slide on postpartum body changes is, again, some of these things that we don't tend to talk about to women and they can be a bit shocked by. Sweating can be common. Oh, hello, flashlight. I've got a little bit of food here left, and the dog has decided that he wants some, if you can see the ears there. So he's just letting me know that I haven't fed him that. So sweating can be common. It doesn't happen to everybody, but that change in hormones can impact on women. So cotton clothing, keeping hydrated, because if you're sweating, you're going to be more likely to become dehydrated. having a towel on top of sheets can just save changes in the middle of the night. So as a maternity nurse, it would be absolutely right and proper when you've taken baby back from a feed or when you're checking in with mum during the night, give her a towel to swap under, just, you know, be that extra help to make sure that she's super comfortable overnight. Hair loss scares some people. It seems to be coming out in clumps. So reassuring mums that that's because it's not that they are losing hair to worry about and they're going to become bald. It is because that during pregnancy, hair loss was stopped. So the hormones said, oh, let's keep all the hair. That's why you have big shiny hair and gorgeous nails during pregnancy, because your body's like, keep everything. And after birth, it's like, oh, we're done with that now. So you get a significant hair loss, and it can be really obvious on hairbrushes or in showers, and it can scare mums. So remind them that actually it's what they would have lost over the past 9 months all happening at once. It's not that they're going to suddenly go bald. Tiredness, of course, pretty expected. So resting and supporting them to rest and supporting them to utilise all of the support that they can get from friends and family. Obviously, our mums are lucky because they've got generally a live-in maternity nurse or night nanny, but even so, emotional support from friends, practical support from friends. Make sure that when you leave, they are still, you know, well supported by their community. Still looking pregnant. Meghan Markle was a great one for this, wasn't she? She actually came out after having a baby and still looked like she'd had a baby, like the rest of us did. And yeah, look what she got in the press for that. It's normal for celebrities or people in the media to be, you know, perfect tummy. It appears straight after the birth. So reassuring our mums that that's not how it's meant to be. You are meant to look pregnant. It's nothing that's wrong with them. It's everything about not being airbrushed. And it's okay to have not had a personal trainer start back at day 1. And we'll hear, if you haven't heard the video from Amber already, listen to it after the session. She talks about when it is appropriate to go back to exercise in terms of the well-being of the mum. So reassuring that that is completely normal. They are not in an airbrushed photo. So this is what real mums do look like. And that celebrate again the fact that they've just birthed a tiny human. They do not need to look a certain way. Dystasis recti is when the stomach muscles separate, and that will have happened over pregnancy for some women. If it has, those stomach muscles should come together over the first 8 weeks. And if it hasn't happened, those mums should be referring back to a GP because that's a medical issue. A red flag. If postpartum mums have a swollen, painful leg, or difficulties breathing, or a high temperature with or without a fever, we need to be calling for medical assistance immediately. This could be a blood clot. So women are more at risk, which is why we talked on the second slide about having those injections for women at high risk groups. But even with the injections, or if the woman was not in a high risk group, this still can happen. So those are some red flags for a deep vein thrombosis, and that is an immediate. That's not just to make a doctor's appointment the next day, because the blood clot could have travelled to the brain and killed her. She has those symptoms. She needs to be phoning into her midwife or presenting at A&E now, not something to hang about with. Okay, right, so that was the physical changes. Any questions on physical changes around our new mums, just the physical?
So just quickly, the swollen and pain is just the legs, or is it other limbs?
It tends to be just the legs. So blood clots can occur anywhere. The legs is where it's most commonly occurring. Which is why if you go long haul, you wear the socks, not armbands. Because simply if you're sitting or lying, that's where the blood will not circulate as well. So yes, it's the swollen leg that seems to be the key trigger.
Okay.
And you know, obviously some people will get blood clots elsewhere, and you know they were less easy to diagnose. So if you have any concerns about the mum, or mum has concerns about herself, never going to dismiss it and say, oh no, the pain should definitely be in the leg because we were told so on our course. You just get the medical help and let the medics assess. If your mum's saying, I don't feel that something's right, you know, and there's any concern, get that medical advice, because they are the people that should be advising her, not you. That's just it's not common, thankfully, but it's the most common presentation. Sally Ann, was that your hand up?
Yeah, I was just going to say, when I had my daughter, after 2 weeks, I could still not sit properly. And the midwife came and said, "Oh, why is?" I said, "Oh, my stitches haven't healed." So she looked. She said, "Oh, your stitches have healed." But it was because I was constipated. I was scared to sit on the toilet, basically. So I thought it was the stitches, but it was actually like constipation. So just to add on that, it might just make things.
Yeah, it's something
Worse
that we
than
don't
they
talk
are.
about much, is it, pooing?
Yeah.
Actually, we need to. And when you watch Amber's video, she talks about pooing a lot. And she gives some good advice around positions to help mum poo. And then we'll also look at later on at the healthy eating to really help with mum. But if laxatives are a really simple fix from the doctor, if healthy eating and positioning hasn't helped, that's something they can do and is not going to affect any breastfeeding of their baby, but may well help them.
Yeah, but I was in agony, like very much. I couldn't do anything.
It's something you wouldn't expect and we don't talk about. So why would you think it was that? But much more common than we realise with postpartum women. Okay, any other questions on physical, or shall we go to mental health? Okay. So there are 3 kind of categories of postnatal mental health that we tend to think about. And the first is considered completely normal. And you might have heard the term baby blues. Just as we've talked about the hormonal changes that happen with breastfeeding to make the breast milk come in, it's the same hormone changes that have an impact on the woman's mood. So the vast majority of women around 3 to 5 days postpartum, when their milk is coming in, get really, really weepy or upset or feel completely, I can't do this, take the baby away, I'm not a good mother. This is super normal. So telling women to expect it in advance means they're more likely to be able to acknowledge and say, oh, okay, I'm now realising that is what is happening to me. Telling the person's partner is also really important, but not being dismissive. It's no use to anyone who's feeling like that to be said, oh, that's just the baby blues. That won't help her to feel at all better. So what could we do when we see a mother who is on day 3 to 5 and you know absolutely certain in your head this is the baby blues? How might you support that mum? What things could you do without dismissing it?
Reassure her.
So knowing it's normal can help, can't it?
Yeah.
Yes.
See if there's any way extra support that she might need to get through.
Yeah. So we're going to think, what can I do for you that perhaps is, a little bit outside of what I'd normally do, but you're having a really tough time at the moment. So, can I go to the shop and get you your favourite snacks? Is some chocolate going to make you feel better? Should we both have just a sit down on the TV? You hold your baby and let's just put the, rubbish TV on. So be there with her, and say, I'm here to go through this with you.
Mm-hmm.
What else could we be doing in terms of helping her oxytocin levels go up? Because oxytocin is going to help with her mood.
If she is breastfeeding, encourage that.
Absolutely true. Why is that the case?
Because breastfeeding increases oxytocin.
Absolutely. So feeding the baby will help in terms of the hormones helping to raise her mood. Skin to skin. So if she's breastfeeding, yes, but if she's formula feeding, she can still raise her oxytocin levels by skin to skin contact with her little baby. So encouraging her to be boobs out, baby here, to feed that baby if she's formula feeding as well. That's really helpful with that oxytocin. What else might she appreciate in those first few days?
A good meal.
A good meal. So it may be outside your scope of practice to cook, but how can you facilitate that happening? Can you be talking to the other partner in the house, if there is one, about the importance of that? Can you be making sure that when it is there, it's cut up if she's breastfeeding and ready for her to eat, so that she's not, feeling that she has to choose between one or the other? Is this the time when you say, would you like me to hold the baby so that it's, because it's important that you can feed? but giving her the choice over what she wants to do. We don't want to make her feel incapable. Oh, you're very upset. I'll take the baby and you eat. That's not giving her any choices. And if you're already feeling down, someone telling you that you can't hold your baby is the last thing you want. So making her feel empowered. What is it you would like? Is this something you would like or not? And being completely fine with any of those decisions she makes. It might be at that time she does want a small amount of time away from the baby.
Yes.
So if she does, saying, okay, would you like to go and have a bath? Okay, if you'd like to have a bath, would you like me to just sit outside the door with the baby on a chair so that your baby's near you? Or would you like me to take them out on a walk? So again, you're empowering the mother to make the right choices for her. She might want a bath, but not want to be separated from her baby. So if so, you can be near. Or she might really relish the idea of just having half an hour when she doesn't have to think about the baby because, you've gone out for a walk. So really giving her the options and saying whatever you want is fine. Let us know what it is that's going to make you feel better. If she has a partner, encouraging them to play their part. So massage might well support with oxytocin. So if it's something she likes, encouraging her partner to give her a shoulder or a foot massage can really help. Giving them some space. So saying, I'm here, I can do this, I can do that, or I can just give you some space to sit and cuddle on the sofa. So not being afraid to say, it's fine for me to step out. What is it that you need? And really listening to what she feels she needs at the moment. But it's very important to not bulldoze her in at that point, because women are in that 3 to 5 day period more likely to feel incapable, and you can do more harm than good by going, well, I'll just do everything. I'll take over the baby. It's fine. That's what I'm here for. Because that's meaning the mum is thinking, well, oh God, I'm not good enough, which is not going to help her mood. So baby blues, we would consider completely normal. Postnatal depression is common, but not normal. That means we shouldn't expect it to happen, but we know that it does in a percentage of women and their partners. So postnatal depression is what we call depression over the first year after birth, whether it is a male or a female partner, whether it's the birthing person or their partner, whatever combination there is. If you're the ones parenting a baby, 10 to 20% of you will suffer from postnatal depression. People who have a history of mental health concerns are more likely to suffer postnatal depression. People who've had depression antenatally are more likely to suffer postnatal depression. People who've had a traumatic birth, be that cesarean that was unexpected, be that something horrid happening during the birth, are more likely to suffer from postnatal depression. But remember, it can happen to both parents, not just the parent who had the baby. We're going to talk a little bit more about that on the next couple of slides. The third type of mental health issue postpartum that you need to be aware of, but you are unlikely to ever see. I've had one case, full stop, one case, is postpartum psychosis. This is a medical emergency. So it's a very serious but very rare mental health condition, and it can be depression or mania or both. Mania is when someone is very high, chatting lots and lots and lots, moving a lot, much more than you would expect from someone who's just had a baby. Usually occurs within the first few weeks after birth, usually occurs in the first few days after birth. So the further down the line you are, the less likely it is to hit. The first symptoms are things like this excited, chatty mood or big depression, severe sleep issues, can't sleep at all, is sleeping all the time. Later on, those symptoms might get worse and you might see mums having hallucinations. This is where mums may harm their babies because they don't have mental capacity at this point. They may be deluded. They may think you're going to hurt the baby, or the midwife is going to hurt the baby, or their partner is going to hurt the baby. They may be seeing things. They might have a loss of inhibition. That means they might be walking around the house naked and not noticing. It's fine, if your mum wants to walk around the house naked after having a baby and you're okay with that as well, that's fine. But when mums are doing this and it seems to be that it's just that they haven't noticed, that might be the loss of inhibition. It might be language that has changed. So you never heard mum swear before, but now she's effing and blinding all the way through. Mood swings, very happy to very sad. So these are all in the very much not normal category. You would either get her partner to call, or if there wasn't one, you to call 111. 999 is if the mother or baby are in danger. So if she is unable to care for that baby, or she's having delusions that seem that the baby may be harmed, or she's not, she may harm the baby or herself, that is actually a 999 call. And if the partner won't make it, you need to. But it is very rare. Good to be aware that it exists. Much more commonly, though, you will see postnatal depression. So these are the ways that it might characterize: tearful, upset, feeling worthless, saying, hang on, this is all baby blue stuff. What we're looking, though, is an extended period of time. So we'd expect the baby blues to pass within the first 10 to 14 days. If after a couple of weeks, so basically if the baby's up to birth weight and the low mood is still continuing, we'd want to be considering postnatal depression. So it's not just a few days of feeling worthless and unhappy, it's consistent feeling. Sleep problems often occur. Low or no sex drive is technically a symptom. She's just had a baby. It's also completely normal. So it is a symptom, but that in itself would not be postnatal depression. That would be called normal having a baby. Anger, difficulty bonding with the baby. Many women will not feel an overwhelming love for their baby immediately, and that is completely normal. So just because in the first few days they're saying, this doesn't feel like my baby, or what am I meant to do with this? That isn't necessarily postnatal depression. It's very usual for women to bond with babies over time, as well as it's very usual for women to have that initial whoosh of love and to feel it forever afterwards. But if the bonding doesn't seem to be improving over those first few weeks, that may well be a sign of postnatal depression. Obviously, suicidal thoughts are a clear indicator of a depression, and we would want the mother to be seen by the GP as a matter of urgency for that. If mum's finding it difficult to do things around the house, difficult to get out, even when you're suggesting, well, should we go for a walk together, and she just feels she can't. If we're over a couple of weeks in and we still have this sort of things from the mum, we'd be thinking maybe she is really not coping well, and this could be postnatal depression kicking in. Is it up to you to tell a mum she's got postnatal depression?
No.
Who should be having that conversation with her?
A doctor or
GP.
Midwife.
Doctor, GP, midwife, health visitor. So you might say things to her and to her partner. I'm concerned about your low mood. A good thing to do would be to talk through with your GP or your midwife or your health visitor. Which of those do you feel you've got the best relationship with? So that you're guiding her towards the fact that she should be seeing a health professional. Which one does she think would be right for her? It's not, postnatal depression isn't by itself a safeguarding issue.
Doctor.
So if she is able to care for the baby but says, no, I don't want to see anyone, thank you, that is not of itself a safeguarding issue. But because postnatal depression can and does interfere with bonding with the baby, then if over time it is not starting to resolve, then it does start to become likely to be more like a safeguarding issue. So you'd be strongly encouraging mum and or her partner to contact the health visitor or GP to check in with them and get some support. Eventually, though, you can't make that decision for them. So if it comes to the point where you feel that the baby's welfare is suffering because of what you think is postnatal depression, at that point you'd need to be contacting a professional yourself, which might be a call to the health visitor to say, I'm working with a mum, I don't have her permission to call you. My concern is for postnatal depression. These are the reasons why. And I've asked the mum to make contact and she's chosen not to. But as a professional, I have concerns that the baby is now not being adequately cared for. So it's at the point at which baby's needs are not being met that would turn in for you to a safeguarding concern. But much better, of course, is to work with the parents, drip effect, to get them to support the health visitor.
So, for example, if you were in a situation where when you were there, she would kind of always give you the baby, not want really much to do with the baby, would you first kind of go to the partner?
I wouldn't first go to the partner ever. I would always first try and have that conversation with the mum. Say about, and I'd get her to say, "How's your day been? You know, how is it going?" Because it may well be that she's perfectly fine and just knackered, and that's your job. She wants you, she's employed you to look after the baby so she can have some time for herself, and that's what's keeping her sane. So it could be not postnatal depression at all, and the thing that's stopping her from getting postnatal depression is the fact that Leanne comes round, takes the baby for 4 hours, and she goes out to have a walk and a coffee with her friends, and that is enough for her. That keeps her sane. So the first thing would have conversations. How are you coping when you've not got support? How is it in the middle of the night? How is it on my days off? So you're trying to gauge what that's like. If you still have concerns about the mother and she's not engaged in that, you've engaged in that conversation, but you don't seem to be getting anywhere, at that point you might then have a talk to the partner. But it's important to try and engage with the mother first. But yes, at that point, if you're concerned, you could go to the partner and say, just wanted to have a chat because I'm with your partner, and it feels to me a little like. And you've really got to choose your words very carefully. That she may not be coping as well as she's making out. What's it like when I'm not here? And it's not telling; it's those open questions to allow the partner time for them to consider for themselves. Because if it's a first time dad or a first time same-sex partner, they're not going to know what normal is. So encouraging them to talk and encouraging them to talk together is really important. But if you get to a situation where you feel baby is being baby is not being looked after adequately because of it, it does then become a safeguarding concern.
Okay.
So for our activity, let's flip onto that slide. Right, so I'm going to put you into 2 groups. I'm going to look at what signs of postnatal depression might you notice, but also, and I forgot to put it on this slide, what might you do to support the mum? So someone is going to, in your group, say a sign, and someone else come in and say, well, what might you do to help support? So let me pop groups on. Hoobie-doobie-doo. Break it. Okay. Right. Sign 1. So 3 of you in one and 4 of you in another. It doesn't matter which room you end up in because it's the same question. Someone say a sign, someone else say a way to support. Okay? 2-3 minutes on this, just a short activity. Let's think of some signs of postnatal depression and what we as maternity nurses can do to support the parents. And when you're feeding back, do consider that not all parents are going to be women. So as we said, postnatal depression can affect men and same-sex partners as well. So if there's anything you've got in terms of ideas to support them, do feed that into the discussion. So does anyone want to start?
We spoke about the mother having low self-esteem, because of her physical appearance.
Great. So that's a symptom.
Yeah.
Fine. Who can come up with something that you personally might do to support the mum who is feeling that? Oh, Sally Ann, I can see talking.
You encourage her.
Unmute.
Oh,
You encourage her.
Encourage her. Is that Habiba?
Encourage her.
No, it's Fiona.
Yeah, you encourage her to say that it's normal.
Yeah.
And maybe sit beside her and watch telly with her.
Yeah. So just chill out with her. Absolutely.
Chill out. Yeah.
Sally Ann, did you have something to add there?
Yeah, we were going to say the same thing as well, and just adding to it, make a nice meal if we can, or the partner can do that. Maybe encourage online shopping, maybe a bit of retail therapy.
Yeah, absolutely. Oh, good idea. I like that. Yes.
And especially now.
Shop. Oh, I think that's very wise advice there. Let's think of another sign or symptom. Someone else with another sign or symptom?
Lack of bonding with baby.
Oh, good one. Okay, so mum is really not happy with this baby. You know, she loves it probably, but she says so, but you're just not feeling that vibe of really tuning into the baby. What can you help her to do?
And encourage her to breastfeed.
Mm-hmm.
We can encourage to cuddle the baby, skin to skin.
Yeah. So use those natural hormones.
Yes. The smell of the baby.
Absolutely. So we know from our earlier work that the smell of the baby, particularly the smell of the baby's head, encourages oxytocin. So you don't have to tell her that's what you're doing, but encourage her to, you know, cuddle in and sniff with her baby, because you're going to be activating those hormones. Something else that's really good is talking through what the baby is doing. So I don't know if any of you've learned to drive. Sometimes in your driving tests you have to tell the examiner what you're noticing on the road as you drive. You know, I'm driving and I can see a car and I can see a pedestrian, they might walk out in the street. You're kind of having to do a monologue of what you can see for safety. Imagine doing that about the baby. It's, oh, can you see they're doing this? Oh, look at the baby looking up at you. Your baby's looking at you. It's amazing. The distance between holding them in your arms and your eyes is perfect, because your baby just wants to focus on your voice. Can you see when as soon as you talk, the baby's reacting and turning his face? So that dialogue was monologue, not a dialogue actually. It's telling, you know, the mum, this is what your baby's doing, can really help her to key into the baby's emotions. Because part of what's lost in maternal postnatal depression is that attunement, the mum and the baby kind of coming together as one. So something we can do if we've noticed and we think that mum is postnatally depressed is to help build the attunement between the baby and the mum. So even if she's not feeling it, you're helping her to see what her baby is doing and to react to it. And it's a bit of don't fake, what is it? What's the phrase I'm meaning? Faking it and making it.
Fake it till you make it.
Yeah, fake it till you make it. Absolutely. The same as you'd advise anyone, you know, if they're going out onto stage or performing, if mum acts like she's doing the right things with the baby, it will help it to come over time. So a bit of fake it till you make it. If she's feeling unconfident, tell her that the baby does not know. So encourage her to be interacting and tuning in with that baby, and really help them by noticing the positives and say, oh, you know, when you did this, the baby did that.
Yeah.
And you can, I'm not saying make it up, but you know, you could over egg it a little bit. I remember when my housemate had a baby, and she managed to give the baby the same name as my eldest. So, you know, she had the baby, we'd been there for 20 hours having a baby, and she turned to me after having the baby and said, right, I don't know how you're going to react to this, but I'm also going to call her Lottie, which is my eldest's name. And I'm like, okay, that's interesting. Yeah.
Lottie.
And I had 2 children, one of which did not share the new baby's name. And they'll, you know, bear in mind, these kids are all going to live together in a mixed house. So I had to tell my youngest one, oh, but you know, yeah, she's got Lottie's name, yeah, but she's got your nose. Of course, my 6-year-old did not know that, genetically speaking, she did not have the same nose. We were not related to that baby. It was just my housemate's baby. But it made her feel really in touch with the baby. Oh, look, she looks like me. You know, she's 6. She's an idiot. But it worked. You know, it was a little teeny white lie, but it worked. So I'm absolutely not telling you to lie to these mums. They are adults. But egg things up a bit is fine. You know, look at the baby. As soon as he does something, it's because what she did. That's fine. Yeah. It makes mum feel better about herself. Yeah. So yeah, look for anything that's going to make mum feel, oh, you did, oh, isn't that wonderful? You've done that. Oh, it's in, and remind her that these things are instinctive. So if she's not feeling those instincts, if anything she does right in terms of, you know, safe sleep, putting the right sort of amount of blankets on, tell her it's instinctive, because that's building up her self-esteem around caring for the baby, which can take a real knock when she's employed someone with years of experience of looking after babies. It can be really difficult for her to feel like she's doing the right thing. So yeah, mediate your advice and make sure you're saying she's doing all the right things. Right, one more sign or symptom, please, that you might notice.
I have one, but I've already spoken, so maybe.
Anyone else want to pop in, or else Leanne's got one ready, so we're not going to go without.
You talk of
tiredness.
Okay.
Tiredness. Okay, maternity nurse is top notch at helping with this one. How are we going to help mum's tiredness without taking over, without her wish?
Doing
Encourage her.
extra things
Oh,
to
sorry.
support her.
Yeah? Encourage her, I was hearing as well.
Rest, yeah.
Mm-hmm.
Get some rest.
Maybe encourage sleep, or say I could take the baby out if you want to relax, and in a way
Get
where you're
some
not telling her.
Yeah,
what to
it's
do,
about
but you're suggesting.
finding
It's
what's right for
suggesting.
her. Will it make you more relaxed if baby and I go for a walk, or if we sit in the next room to you? Because for some parents, actually, it won't help them to relax knowing their baby is further away. So phrasing it in a way that gives her those choices. Okay.
Encourage her to have a bath,
Encourage her to
take a bath.
take a bath. Yes, absolutely. Unless she's had a cesarean scar and she can't for a little while, then a
Okay.
relaxing herbal bath.
Yeah.
And again, making things really nice for her. And, you know, it's absolutely within your scope of practice to run a new mum a bath. Definitely counts as, you know, something that'd be good for a maternity nurse to be doing.
Do you mind if we just take a quick break? I just need to grab another charger.
Sorry, I did not offer a break today, so please,
okay.
absolutely. We'll take a couple of minutes,
Grab a
everybody.
charger.
So sorry, take a couple of minutes. I think or else Leanne might lose on the old computer there. We might lose her completely. Any questions whilst we're waiting for her to return?
Oh, I wanted to say,
Yep.
you know, it don't come natural when you were talking about it, trying to make the mom engage with the baby.
Yeah.
I don't think it really comes natural for mothers to speak to their newborn baby, because they kind of think, oh,
yeah, for
yeah,
some
it doesn't for
some
all.
it doesn't. So what could we as
So-
maternity nurses do to support that?
Maybe just to encourage her to have a conversation with the baby, like you were saying that, oh, the baby will understand what you were what you're saying as well. So just to encourage.
And also
that.
modelling can be really helpful. Sorry, Alethea?
Leading by example. So when you're caring for the baby, talking to the baby all the time. And
Absolutely. If
Yeah.
mum feels stupid talking to the baby because it's a tiny person, you can make her feel less daft by you doing it all of the time.
Yeah.
So have that ongoing conversation that most of us will do naturally because of our many years of experience of, oh, we're doing this now and we're doing this and now I'm going to do this and now I'm going to do this, and we don't care what we sound like because that's just what we do. So
Yeah.
the more we can model that to the mum, the better she's going to feel about doing it herself. And you can have the adult conversation with her. You may, you know, I'm sure you think that I sound daft doing this, but babies really love it because. So you can have that conversation with her. Okay, so the next slide I've got up was just to check we've got other ideas. Can I add yours? Sally-Ann, can I steal your idea?
Yeah, sure.
Add it to the list? Any other
Little
ideas I should have added to the list that weren't on here? So eating regularly, healthily, getting showered and dressed every day. Now there's a difference between saying to mums they should look like their pre-pregnancy self and all fully made up and everything, and just encouraging mum to take a few minutes to herself, because although it's completely fine to be in pajamas when you've just had a baby, absolutely fine and normal, if a mum is suffering from postnatal depression, and remember this is something that we're thinking is kicking in after about 2 weeks or more after the birth, that low mood has not started to raise, this is not day 3, this is a few weeks in, then actually showering and suggesting she gets dressed every day is going to help to get her going and actually get her doing something to help raise those hormones. But this is not talking about a mum who's 2 days in, because we wouldn't count that as postnatal depression. Trying to get outside every day, we know that's good for all of our mental health. Building a support network. Keeping a mood diary. It can be really good to encourage mums to keep their own mood diary, to notice when things are better and worse. That will help them to identify triggers for themselves over what helps them to have a good day and what helps and what hinders them from having a good day. So mood diary is a really good idea. Trying a baby massage course. Why might that be a good idea?
It will help them to bond with their baby.
Bonding, oxytocin. Yeah. Helps their attunement and attachment. So although you're suggesting something for the baby, actually the majority of the positives there are for the mum. Journaling, and when you look at the PDF of this file, you'll be able to click on that link if you don't know what journaling is. but it's around writing diaries and writing in a way that is going to help you to get things that are in here and worrying you out onto the paper. And again, these are not things that will work for everybody, but it's good to have a list of things to try, because when you have postnatal depression, what you don't have is a whole long list of things that you might want to try because you're feeling depressed. So your maternity nurse saying, some people have tried this and have found it help. Some mothers I've worked with found this helps. Doesn't mean it's going to help her, but it gives her some options. Some might want to listen to relaxation tracks or meditations, lots and lots of them on the internet. And again, on the link, you'll have some you can access. Things like mindful colouring. It's been a big thing recently, hasn't it? You can buy them in any newsagents, those sort of little tiny colouring books. You colour mandalas and all sorts of things very carefully. Wouldn't work for me, but for some people, it really does. So it's about giving them a whole host of ideas that then they can choose what is right for them. This is a super important one, thinking about good enough parenting rather than perfection. And the science on this is really clear. To have healthy, well-developed, emotionally developed children, we need to be good enough parents about 51% of the time. That means that if we're a bit shit some of the time, but mostly over half of the time we're okay, fundamentally our kids will be fine. We don't have to be perfect all the time. We don't even have to be good all the time. As long as the balance between when we do the things and when we don't do the things tips in favour of doing the good things, our babies will be okay. So obviously we're not talking about abusive situations. That's never going to be a balance. We just don't want that to happen at all. But in terms of, getting to the baby, when they're crying straight away, in terms of getting out every day, in terms of getting the baby dressed every day, as long as we're doing it more than we're not, that's good enough, and our babies will survive and thrive. Taking light exercise, again, it's something that might feel a bit impossible if you're depressed, but we know that in general exercise does raise the endorphins and can support. So anything you can do to support that light exercise, and we mean by that going for a walk. We don't mean going for a few mile jog. It's getting out, it's going for a walk. And then I put retail therapy on because that was Sally Ann's good idea. Okay. Here are some organisations, and again, you don't need to note these down because they'll be on the PDF file that we send out and you'll be able to check on those links. Couple, first of all, for fathers, as we've just said, that fathers can also suffer postnatal depression and often suffer without sharing. Fathers can also go to the health visit to the midwife or the GP. It's not just a female-only preserve. But these couple of good websites, particularly aimed at dads. Mine is a support network for all mental health issues. But there is a page on perinatal mental health. Perinatal means the whole of the pregnancy to postpartum journey. So perinatal mental health is any mental health from when you've conceived all the way through until a year after you've had a baby. The Association for Parental Newborn Postnatal Illness, APNI, is really focused on postnatal illness, and they've got a big support network there, lots of information. And then PANDAS is again postnatal depression. There's something in the acronym there that's spelled PANDA somehow. And they actually have a helpline service which mums and dads both can phone. So again, you don't need to have these to hand, but knowing that you can come back to these slides, or if you think someone needs suggestions of people to talk to as well as their GP or health visitor or midwife, these are places that you can pop them to. Okay. So we're going to go into 3 groups. This is going to be a take a photo, please, because we know it can't be seen later. Room 1 will have family 1, room 2 will have family 2, room 3 will have family 3. And the question is, what support would you particularly offer to these families? So you're looking at the situation, and obviously it's going to be very dependent on the person. But in general, what things could you offer these families? What would you suggest in your role as a maternity nurse? Who's going to tell me about family 1, where the couple's rainbow baby, which is a baby born after the death of a first or another baby, has arrived. So just a new baby, super nervous parents, got all the things. So they've got an owlet on the toe, they've got the, you know, angel baby care monitor underneath the bed, they've got the camera on the room, they've got the camera on the cot, everything happening. And you know, unsurprisingly, Mum was diagnosed with depression after the death of her first baby. She came off that medication in the third trimester because she didn't want to have a problem for this, you know, with the baby, in terms of if you do have antidepressants in the third trimester, there are some risks with that baby in terms of their breathing and well-being. So she chose to come off that medication. Room 1 people, what would you offer in terms of support for these families?
So that was me and Sally Ann, room 1. We said that we give them assurance that we know their concerns, and that we like come into the every day with energy, and like we are alert, and we could teach them about like their safe sleeping, and just so that they air their concerns to us, and we know we are aware of what they want us to do. Sally Ann?
And as well about the depression. Mom has had depression. I think it's best to encourage network of mothers in the same situation.
Yeah.
And encourage time of bonding with baby on her own, and just maybe reassuring that we are the extra help that she needs, so that she stops worrying too much.
Yeah, that suggestion of bonding with mums in a similar situation is really important. Having a rainbow baby gives you all sorts of mixed emotions about whether this is going to make you stop loving the baby that you lost. There's all sorts of really complex things going on. So having a meeting up with another rainbow group of mums or parents who've experienced the same loss as you, or different circumstances for everybody, but similar feelings, can be really helpful in helping new parents process those. That's a super important suggestion. Have a think, she came off her medication recently in the third trimester. So obviously medication isn't your bag, your maternity nurse is not medical, but what might you be suggesting that she does in relation to that?
We as a maternity nurse, we thought we could like monitor her behavior, so that we know if there's certain things that are triggers, and also obviously with depression we would give her options of, do you want to go for a walk with as a family, or with me and the baby, just like getting outside and trying to a bit of normality, like she would have done post baby.
And with that medication, it's really important that you have a conversation with her. Say, did you come off medication with the support of your doctor? Does your GP know? And if they don't, actually that coming off very quickly can trigger depression. So they need to get back to the GP for a talk. It's not to you to decide whether they should have medication. They need to talk with their GP about the pros and the cons. And actually there's much medication that even with breastfeeding you can take, and generally women would be advised not to come off antidepressants. So the fact that she has makes me feel it would be well worth her going back to the GP, and actually I don't think she probably has had that conversation. So there's some pharmacological support that can be available to help raise her mood as well.
Yeah.
Okay, who is in room 2 with family 2?
Fiona.
Okay, so you've got twins with a single mum.
Yeah.
And she's very tired. What a surprise. A single mum of twins. Who'd have thought it? She's a breastfeeding mum. She's breastfeeding these little bubbers. So she's not got much time to eat and drink. She looks tired. She looks pale. She says she's fine. So she's fine. So she's employed a maternity nurse or a night nanny overnight. What support are you going to be offering this mummy?
She needs to make some routine so that it helps her and give her help, because she can't manage, or she don't have enough time to eat and drink. Maybe we can prepare her meals. Yeah. And then
if you're
after
not
breastfeeding
choosing to cook, then how, could you find someone, or can she pay for someone to batch cook for her? Is there community support? I had one lady whose church all cooked a meal and put them in her freezer. So is there a group of friends that could do that?
Yeah. And after breastfeeding, we can take the baby so she can have a rest.
Yeah. Who else was doing this one?
Fiona and Habiba.
Yeah.
We take the babies out for fresh air while she has some rest. And what else? She said it all.
Other things you can do. I know you've talked about routine. Obviously, it's important to find out what the mum wants, but helping babies to feed at the same time so that they sleep at the same time is really good for twins.
We even talked about asking her to pump the milk out, put it in freezer bags so we can help her feed the baby.
If that's her choice, absolutely.
Yeah.
It can be really tiring to be breastfeeding and expressing
Yes.
milk. It can be easier for her to just boob. But it's about talking and saying, well, these are options. What do you think would work best for you?
Yeah.
Do you want to do additional expressing and then have a chunk of sleep when I can see them? What works well?
Yeah.
I looked after a twin that mum was exclusively breastfeeding, and she would have the M pillow, and basically every time she was going to feed a big feed on the M pillow, I would take her food, her drinks, and put it all around her.
Literally.
So that,
Feed her. I've done that before a lot. I'd introduce this mummy to slinging. I would sling these babies to give her some time and some hands free. When I'm going around, I'd sling the baby so that I can help a little more around the house than I might normally, because I've got babies in the sling, they're going to be happy. So that might be something that really helps. But yeah, like you said, having a feeding and changing station so she's got, you know, everything she needs, but also making sure the rest of her house is set up as efficiently as it can be, so that she's never having to spend additional time looking for nappies or going to another room to change the babies. Let's make each room have a changing station so it can be super efficient. If you've got Moses baskets downstairs, making sure that she's got, you know, a duvet downstairs that she can just snooze on the sofa. If they've suddenly fallen asleep, she can then grab a few winks. So trying to make it kind of as efficient and streamlined as possible. Does she need any medical help here?
Yes, because she's pale.
She's pale. She
Yes,
may be
very
anemic.
Very
Anemic.
So you're not going to
Yeah.
diagnose that, but you are going to suggest she goes and has perhaps a chat with the GP and an iron test to see if there is any anemia. Because if so, actually a change in her diet or additional supplement could really help her to
Maybe she
be
needs
better and
vitamins.
healthier. Right, family 3. So you guys have a new mum who is constantly in tears, and we're at 6 weeks now. And her partner, who is also mum, doesn't seem to be able to put her foot right. So the birthing mum, the woman who had the baby, is doing most of the care, and as soon as her partner tries to step in, she's snapping at her saying, you can't do that right, you're doing that wrong. They seem very fraught, and the birth mum just feels unable to leave the house, but she just doesn't trust her partner to go either. So she worries about the baby when her partner's looking after it. How could we support this same-sex family?
So one of the things we thought is it's about supporting the relationship between both mums and encouraging them to sort of remember why they're together.
Yeah, that they had this baby together because they loved each other.
So it might be, you know, so it might be offering for them to go out while you stay with baby, or you go out with baby so they can spend some time at home together.
Yeah.
And just spend a bit more, have a bit more communication. But also, birth mum obviously is very tired because she's doing the brunt of everything. So might offering her opportunities to rest. So she's better able, but also finding a way. Obviously, it's not until you know people that you kind of know how you might suggest.
Absolutely, these are general suggestions. Of course, they'd have to be
suggesting for her to encourage bonding with the other mum.
Yeah, absolutely.
And she could offer suggestions to the other mum how she maybe enjoys things, or relax her a bit more if she feels that the other mum's starting off doing things the way she did them. And then you get like slowly over time underway.
Someone's computer's tapping. It's really difficult to hear. So yeah, lots of good suggestions there. We can suggest, I mean, 6 weeks is quite late, but it's important to know that same-sex mums who are not the birth mum can induce lactation. So if you're working with same-sex female couples antenatally before they have a baby, Talk to them about it's a possibility that if the birth mum's choosing to breastfeed, or well, actually doesn't matter at all what the birth mum's choosing to do, the other mum can induce lactation. She can work with the lactation consultant so that she can actually breastfeed. Generally, induced lactation won't provide all of a baby's nutritional needs, but it can help out in terms of that bonding, that additional feeding, that sharing the time and sharing that bond. So just something to be aware of. It's completely possible to breastfeed when you haven't birthed a baby if you're a woman. Adoptive mums can also do that. So if parents have had an adoption or a surrogate pregnancy, they can work with a lactation consultant, and it doesn't happen every time. It's not 100%, but there are support that they can have to actually induce that breastfeeding, even if they haven't birthed a baby. So important bit of knowledge there. Okay, good work. Right, who's who? So this was just a slide around who else is likely to be coming to the house, or you're going to see them during this postpartum period, because it's good to know who does what. So the midwife officially is involved for 28 days after the birth. In reality, after about day 10, they hand over to the health visiting team. So they're very unlikely to be seen in the second 2 weeks of the month. They're officially there, but generally would only get involved if there was a clinical problem. As well as the midwife who will visit the home, you might have an MSA or an MSW. That's a midwifery worker or support assistant. They are non-clinical, so they will help, and they may have good breastfeeding training, and they may have very supportive ideas, but they're non-clinical. So just like you wouldn't diagnose anything, neither will they. But they can be a good support to new parents, and they can help the midwives to see more mums. So around day 10-ish, your health visitor will phone or visit to introduce him or herself. And that then is the key professional for this baby until they are 5 years old. So until they've completed their reception year at school, or if they're homeschooled, until they're 5. So that is always a trained midwife or nurse. So it's someone who has additional training to that to work in the community. So less so during COVID, but generally they will run weighing clinics where people can go and get their babies weighed and get additional chat and support from the health visitor. So this is for the thing that you want to find out something about your baby, but that they're not going to get ill because you haven't done it yet. So illness, we're going to go to a GP. But my baby doesn't seem to be doing X yet. My baby hasn't smiled yet and they're 7 weeks old. That's the sort of thing that mums will be asking their health visitor. Oh, my baby's not walking yet. Is this normal? Should they be doing this? This is how much they weigh. All of these things are well within health visitor capabilities. So they will offer support around feeding, health and infant development. And if they have concerns, they will refer on to additional professionals. So the GP or general practitioner is what we used to call a family doctor. So that's the first point of care for general baby health and vaccinations. GPs are supported by their practice nurses, and dependent where you are, practice nurses are taking on more and more of the clinical roles. So you actually might not see a GP with an unwell baby. They might go straight to the practice nurse if that's their area of expertise. They'll generally do the vaccinations, but it depends on the surgery, how they've set up. So yours might or might not in the place that you're working. So concerns about the baby's health, but also those concerns about parent health, both physical and mental, goes to the GP. American parents particularly, but also other parts of the world, will be really keen to see their paediatrician. In the UK, you will not do this unless you have a particularly ill baby. So the American model, also used in other countries, is that instead of a general practitioner for children, they have a paediatrician, so a child doctor who deals with vaccinations, infant health. In America, they give them books to read as part of the Reach Out and Read program. They do all sorts of things. The UK role for a paediatrician, as you'll have learned from the video with Dr. Vicky, is that they work with sick children, or they have referrals in their specialist area. So there are such things as community paediatricians, and they assess autism, that sort of thing in the community. But again, it's a referral process. You don't just go and see a paediatrician unless your child is ill in hospital, and then the paediatrician will be in charge of the ward where they're admitted. Any questions on who's who for health professionals? Hopefully something everybody's familiar with.
Well, pediatricians in Portugal are exactly the same as in US.
American model, yeah. So your families won't see a GP or a health visitor, they'll go straight to the pediatrician for all of their checks.
We don't have midwives coming to the house, health visitors. We don't have none of that.
So after the baby comes home from the hospital, if they're a hospital birth, just the pediatrician for everything?
Yes.
Yeah.
And what about the mum's health? Who does she go and see?
She can go to our GP.
Mm-hmm. Or a midwife.
The baby will go to the pediatrician.
Okay.
Okay.
Thank you.
You're welcome.
I find it very interesting, the models that take apart the baby and the mother, because often the problems are that. So if a baby's not feeding well, if it's breastfeeding, that's a mum problem as well as a baby problem. So it's interesting, the different models, you know, where the mums get that support. So a paediatrician is unlikely to have much lactation training.
Exactly.
Although, to be fair, neither do GPs. But yeah, they're interesting models. It's just important to know, help your parents understand, because often if they're foreign nationals in the UK, they'll often be under an American model where they've lived. So they're like, well, why can't I see the paediatrician? And be really confused why they cannot see a paediatrician when their kid has a rash. And we need to explain that, you know, the models are different.
Yeah.
So I'm going to talk just a little bit more, because I'm going to finish on time, because I'm getting, you know, by the end of the course, I'm like, way, we'll be finished half an hour early. No, we won't. We're really not. There's loads next week. Relationship changes. So we've talked a little bit about some of these already. So just saying that when a baby's born, there are changes and adjustments to all of the family roles and relationships. And the more people can talk about this, the better you can support the families. So transition to parenthood is huge, even if it was a planned pregnancy or a long-awaited pregnancy. When people have a baby, it's not how they imagined it would be. Probably few of us would have babies if we knew quite how tough it was before we started. Very worthwhile, but super tough. So that idea of building up over the 9 months or much longer of what it will be like when we're parents mostly involves kind of going to the park with the pram. That is not a big part of parenting. So those responsibilities can really hit home. Actually, most of what you're doing is either boobing or feeding or trying to get them to sleep or changing nappy. You know, it's not the fun parts that you might have imagined. Those come later. And those responsibilities, suddenly you have to care for a whole tiny human, can be really difficult, especially when parents have been in NICU or they've had neonatal care. The nurses have done a lot of the care for their infant or infants, and they come home and suddenly they've got to keep this tiny human alive. That's a big one. And certainly in COVID, women have been discharged from hospital much quicker than they were pre-COVID. So it could be sort of 6 hours after having a baby, off you go, that's your lot, keep it alive and we'll come and see you tomorrow. So big, big responsibilities. Differing opinions. Many couples don't talk about all of the different things in terms of the parenting that they would like to do. And it can be affected a lot by our own, how we were parented. Either that we do not want to parent in the same way, we'll do everything the opposite to our parents, or that this is the only way that it feels right to parent because it kind of worked for us. And that's two families coming together with all of their different parenting expectations can be really difficult to deal with. And you put that into a situation where often one parent is doing much more of the caring than the other. Often it is the birth mum who is doing more of the caring, especially if she's breastfeeding. So they have a larger amount of time that they're spending with that baby. That balance, as we looked at in scenario 3, can be really difficult to get right. Extended families. So, you know, when you get married, you know, you might have a meal with the two families together. They might sit on opposite sides of the church and walk out together if you have a religious ceremony. That's pretty much it. That's all they really have to do. But when you have a baby, two families now have to come in for everything. They all want to see the baby. They all want to spend time with the baby. They've all got opinions. They're all, you know, grandparents or aunties or uncles. And so even before you hit that sort of first Christmas, where should we go for Christmas? And some families end up doing one family this year, one family next year. Before that, you've got those very new weeks where the new parents are trying to form their family and the extended family are trying to be part of that, which is right and proper, but really tough. So something with a maternity nurse you might well end up being is the gatekeeper. It's okay for you to be the person who says, I'm really sorry that you can't come round Auntie Jean, but she's feeling really tired today. Because, you know, after 12 weeks, Auntie Jean will never see you again. Whereas mum or dad or the other parent having to say that can really ruin a relationship. So a really good role you can play for parents is to be the gatekeeper, to be the bad guy. It needs to be what they want, of course. You're not the one saying Auntie Jean can't come. You need to have that discussion. Who would you like round? Who would you like me to, you know, put off for a little bit? You know, would you want to see Auntie Jean? Would you like me to come in at any point to say that the baby needs X? Bit like, you know, when you go on a first date and you get your girlfriend to phone up and go, oh, you need to come home now because things aren't going so well. Those sort of checking up phone calls, you can arrange that with parents saying, would you like to come in after half an hour and say, would you like, you know, does the baby need a feed now? And they can use you as an excuse. So you can do a really valuable role there in making sure the parents don't have any of that conflict with their family, because it's not your family, it's not your circus, not your monkey. So you can be there to support them in that way. Sex and intimacy, I say that lack of a sex drive can be a sign of postnatal depression. It can be obviously completely normal because you've gone through childbirth and you're now not sleeping. So just encourage couples to be open with each other, not with you. You do not need to be a three-way relationship counsellor here about their sex lives. That's not your job. But encouraging them to be talking to each other is really important. So if mum is saying to you, oh, you know, she's feeling like this, or she's feeling a bit rejected, it's not for you to go and tell dad that. It's to encourage her to have that conversation. And so you can say, well, would you like to have some time? Would it help if I took baby out for an hour this evening on a nice long walk whilst you have that chat? So you're not a relationship counsellor, but you can help them by helping to create space for them to talk and to be a couple. And then finances. So having a baby is super expensive anyway. Having teenagers, though, is much more expensive. So they've got all that fun to come. So I went to Tesco's today, £100. How did that? We didn't even buy any food.
Yeah.
But they might be on a reduced income. If someone's given birth, if they were working before, they're likely to be on a reduced income on maternity pay. And maternity nurses are a luxury. Not everybody gets this. It's a luxury, and parents are choosing for this support. So this is your business. And although you're all lovely people who want to help everybody, you cannot do that for free. Because if you do it for free, you won't be able to pay your own bills or look after your own family. So if you've got a family who are interviewing, they really want to work with you, but they're saying, oh, you're a bit expensive, and they play a few of the cards, well, mum stopped work, or dad just been made redundant, or, we're having some problems. Always suggest that they can have you for fewer hours, if that's what you choose, rather than lowering your rate. So maternity nurses are a luxury. No one, unfortunately, gets a maternity nurse because they deserve it. It's because it's a luxury that some people can choose to afford. So if they're saying, oh, well, it's a bit expensive for us, okay, completely recognise that. I'm happy to offer 24 hours for 5 days a week instead of 6. Or, yeah, I could work with you for 2 nights a week instead of the 5 you were talking about. Obviously, you won't say that if it's not what works for you. If working 2 nights a week does not suit you, do not take this job. But it can be something to think about. If someone's querying the price, don't drop your rate, but offer them fewer hours. And you will then very quickly see whether someone is valuing you and wants you, or is trying to get a deal. And from experience, the families who are trying to get a deal are genuinely the wealthiest ones. And I've had a family who did get a deal from me. And then and this was a lovely couple in what they said was their mum's flat near Hyde Park. When I eventually turned up when the baby had come, obviously to Portland, which is a very, very expensive maternity hospital if you don't know. Yeah. They were there with their servants, and their family were there in 2 other flats that they owned in this Hyde Park apartment. So they're in 3 flats. We flew back home with them on a private jet. Yes. They're very nice private jets, I must say. Very nice. And when we flew back home, we went to a palace. It was a palace. So did they need to get a deal?
No.
Whose rent do you think was more important, theirs or mine?
They probably didn't have any rent.
Yeah, exactly. You know, I'm not well off. I do fine. We're okay. I'm not complaining. But I'd taken a cut because, we'd say, well, they wanted me for this amount of time and yada, yada. I was like, okay, well, I want the work. So, I will. I know they're interviewing quite a few people. This work suited me for various reasons. So I took a little cut for that. How did I feel for that 6 weeks?
Awful.
Like they had taken advantage.
Yeah. I felt a bit robbed, actually, because when they went to get something from the baby, or they wanted me to get something from the baby, I was sent to Harrods. Baby had a jumper which cost more than my daily rate. Baby actually a jumper, it cost more than my, I was worth less to them than the jumper for the baby. So I felt resentful, and I hope they never knew that. But it was a lesson learned for me, that the people who are most likely, and I've had it, I've seen it with others as well, but only got caught once. People are most likely to bargain are the people who can afford you.
Can afford, yeah.
And one of those things about being rich, isn't it? How do you stay rich? By getting things cheap. So my learning from that, which I will pass to you, so you don't have to spend 6 weeks feeling resentful in a palace, although private jets are very nice, is, okay, I really appreciate you're struggling here. Yeah, having a baby is super difficult. I'd love to work with you, so I can offer you 5 days a week. I would normally only take 6 days a week work, but I will offer you 5. How does that work for you? Because then this is the rate that you'd pay, which is what you were wanting. You were saying you could only afford X a week. How does that work for you? And you'll soon work out whether they want you or whether they're trying it on. Obviously only do that if that's what you're prepared to do. If you're a night nanny and you need to work 5 nights a week to pay the rent, don't offer them 3, because it doesn't meet your needs. Don't take the job, but don't undersell yourself. Okay. Oh, sugar me, it's 9. How did that happen? Oh no. Healthy eating. Eat stuff, it's good for you.
Okay.
I really hope that you mostly know about healthy eating. This isn't a healthy eating course. Here are some great ideas for snacks for new parents. You can read them in your own time. They're snacks. It's nothing new.
Okay.
But some good things that you can eat whilst breastfeeding. Cover up the baby with a muslin. I've often fed mums because they need to eat and they need to breastfeed, and it's tough. So we were going to just do an activity, say what your favourite foods to make or recommend to new mums. But because it's 9 o'clock, I'm going to invite you on the Facebook group to pop on any of your favourite foods to make or recommend to mums. So if you've got a favourite recipe or something you say to mums, try this, it's lovely, really works, then please put it on the Facebook group. The important learning here is around how to make mums more comfy. So remembering that breastfeeding mums get super hungry and thirsty, so top up their healthy snack bowl and make sure they've got full water bottles. Hot drinks, it's a no-brainer. Don't have super hot drinks near a newborn. It's not going to end well. So mums are really used to drinking cool tea, and it is a safety thing. So either have it in one of those, I haven't got one around, but one of those sort of coffee cups that has the lids on that you can't spill, that keeps them hot, thermos flask things, or let them cool a little before they come near the baby. And then our last slide was going to be around postpartum traditions. So just saying that different cultures have different traditions. Sitting the month is something that can be quite common, or confinement, which means that mums are invited to stay in their own home with the baby. They're not expected to go out and about. They're kept very warm, fed very nourishing foods. Often mums who are living in the UK can find that balance quite difficult in terms of what their relations are expecting and what their friends are expecting. where those traditions can kind of clash with their current lives. So it's just about listening to mum saying, you know, how do you best want to be supported? One things we do come up against in terms of postpartum tradition is heat. Often mums who are sitting the month, if their mother-in-law or their mother is there, they might tend to try and keep the room very warm, and we're going like optimum temperature for baby 16 to 20. So there's a balance, and it's up to the mum to make the decisions on what's right for her. So you're listening to what's normal for that culture, you're giving what's the UK advice on safety, and you're letting the mum make the right decision for her. So again, I was going to ask you about any traditions around the world you're aware of, but I'm going to finish on time and ask people if they want to put that on the Facebook group instead. Okay, so I completely forgot about the time there. I'm so sorry, but it's only 4 minutes. We're getting better. Next session, Thursday, is all about running a business. So if there are any questions that have come up about mums and babies, can you email them, message them, or put them on the Facebook group for us to deal with in the last session? Because the focus is going to be on working, self-employment, how to get interviews. So not on the nice bits of being a maternity nurse, the mums and the babies. It's on the bits that we need to know to be business women, and to make sure that we're, you know, making money and paying our bills. So that is our focus for the last session, and we'll be talking to a very well respected maternity nurse, Karen. She'll be coming with some question and answer session. So she'll join us for part of the session, and I'll have some questions for her that I've lined up already, and then there'll be an opportunity for you to ask another working maternity nurse just anything you want about what she's doing, but she's one of the most successful, well-respected maternity nurses in the industry at the moment. And we'll have a web video for you from the agency, Silent Night Nannies, and that will be an interview talking around what the agency would expect from a maternity nurse or a night nanny. And we'll also be going through things like rates, how much shall I charge? So very business and work focused. So if you've got questions about the mum and baby part of what we've been learning, send them in to me some way, and we'll have a part of the session where I will deal with those questions. But we won't have much time because we've got the interviews. So make sure that if you sent them in advance, I can prepare and we can answer them. We won't have a long extended open session, but we've always got the Facebook group for questions as well. So homework is going to be a quiz you're going to be sent, and that is on newborn health and illnesses. So you'll need to complete that. Only a couple of people now haven't sent me their videos, so I'll need those through in the next couple of weeks. And then we'll tell you on Thursday when you'll be receiving your assessment. Your assignment is just being signed off by OCN, the awarding body. So by Thursday, I'll know when that's being sent out. So the email tomorrow will have midwife video, postpartum videos already up, and it will have the quiz on infant health that you'll need to complete. And then I'll see you on Thursday for our very last session, when we will definitely do a photo. Make up and remind me, okay?
We will make up.
All good. Right, okay, I'm here if anyone has any burning questions, but if not, I'm going to let you go. See you Thursday.
Caroline?
Yes, Sally-Ann.
Did you say we're having a quiz to answer between now and Thursday?
You're having a what, sorry?
A quiz we should answer between now and Thursday?
Yeah, it's a quiz on newborn illness. It's instead of a video this week, so it's your homework. You do not have to have completed it for Thursday. You need to have completed the videos and the quiz by the time where you submit your assessment. So the sooner the better, because then I can keep a better track, but you don't have to do the quiz by Thursday. I'm sending it out because it's related to our last week's work. So
thank you.
Sooner rather than later, but everything needs to be done by the time you give the assignment in, because that's all ticked off for different things. Good question. See you later.
Thank you.
See you.
Bye.
Bye.
Bye, everyone. Good night.
Night night.
Night.